Good evening and welcome to tonight's webinar, brought to you by the Journal of Bone and Joint Surgery. Tonight's topic is What's New in Diagnosis and Treatment of Carpal Tunnel Syndrome. This is Mark Swinkowski, Editor-in-Chief of JBJS and host for tonight's webinar. Through technology platforms such as this webinar, we are able to provide content that is important, timely, and available in an interactive format in the comfort of your office or home. With about 500,000 carpal tunnel releases performed a year in the United States, carpal tunnel syndrome is a condition that affects 3 to 5% of the general population. During the next hour, we will be discussing the appropriate diagnostic methods and the role of advanced electrodiagnostic testing and ultrasound in diagnosing carpal tunnel syndrome. Additionally, we'll examine postoperative care and managing patient expectation after unilateral and bilateral release. During this webinar, you will hear from JBJS authors Dr. Daniel Assay and John Fowler. Each will present the findings of their research. You will also be hearing from two expert commentators, Dr. Jay Pomerantz and Dr. Marty Boyer. Tonight's webinar is moderated by Dr. Brent Graham. All four experts on the panel will address questions from the audience to provide further insight into diagnosis and treatment of carpal tunnel syndrome. I know that you will find the next hour stimulating and informative. I also want to thank our sponsor tonight, Modernizing Medicine. Before we get started, I want to make sure you get the most out of this webinar. There are a few ways you can participate in tonight's event. You are welcome to ask one of our panelists a question by simply typing your question in the Ask a Question bar, which you will see below the slides. When you're done, simply press Submit. Feel free to submit a question anytime during the presentation. You can also read our speakers' biographies. The handout widget at the bottom of your screen contains PDFs of the two articles presented tonight, as well as information from tonight's sponsor, Modernizing Medicine. Additionally, the slides from tonight's webinar will be emailed to you tomorrow at noon. Now let me introduce our moderator, Dr. Brent Graham. Dr. Graham is an attending hand surgeon at the University Health Network in Toronto and also a deputy editor for methodology and biostatistics at JBJS. Dr. Graham is currently chairman of the AAOS Clinical Practice Guideline Working Group for Diagnosis and Treatment of Carpal Tunnel Syndrome. Previously, he was research director at the American Society for Surgery of the Hand.
Thank you, Dr. Swinkowski, and thank you for the privilege to moderate what I anticipate will be an exciting and informative event. Tonight we have four outstanding speakers who are all experts on carpal tunnel syndrome. The first JBJS article to be presented was authored by Dr. John Fowler. John is an assistant professor at the University of Pittsburgh Medical Center in Pittsburgh and an orthopedic subspecialist in hand, upper extremity, and microvascular surgery. He is also director of research for the UPMC Hand Fellowship. Our second author, Dr. Daniel A. Assay, is an orthopedic specialist in hand and wrist surgery and in microvascular upper and lower extremity reconstruction at Washington University Orthopedics in St. Louis, Missouri. Each author presentation will be followed by commentary by an expert in carpal tunnel syndrome. Dr. Marty Boyer, professor of orthopedic surgery at Washington University School of Medicine, will comment on the first paper, and Dr. Jay Pomerantz, who is a board-certified orthopedic hand surgeon affiliated with multiple Chicago area hospitals, will comment on the second paper. We will save the last 15 minutes for questions from the audience. The questions can be sent in at any point during the presentation. Dr. Swinkowski will help me identify the most relevant questions, and I will direct them toward one or all of the speakers. Now, let's begin with Dr. John Fowler.
Well, thank you, Dr. Graham. I appreciate the opportunity to present my research. Carpal tunnel syndrome is one of the most common disorders that we see, with nearly 4 million patients presenting to a physician per year for evaluation of carpal tunnel symptoms. It is the most common compression neuropathy of the upper extremity, with an estimated prevalence of 5% in the general population. The AAOS Clinical Practice Guidelines recommend obtaining electrodiagnostic testing and patients in whom surgery is being considered. This was a grade B recommendation based on a high level of evidence in the literature. For the purposes of this study, electrodiagnostic testing is defined as a combination of nerve conduction studies and electromyography. Although debatable, electrodiagnostic testing is considered by many as the current gold standard for diagnosis of carpal tunnel syndrome. In most studies, electrodiagnostic testing has a high specificity, making it a good confirmatory test. However, other studies quote a false negative rate of 16 to 34%. Ultrasound is an alternative diagnostic test for carpal tunnel syndrome. The cross-sectional area of the median nerve is measured at the carpal tunnel inlet. Cross-sectional area cutoffs have ranged between 9 and 12 millimeters squared in most studies. This is a clinical image of an ultrasound performed at the carpal tunnel inlet. The ellipse is placed just inside the hyperechoic epineurium. The computer software calculates and reports the cross-sectional area of the nerve. Ultrasound has been used since at least the early 1990s for confirmation of a clinical diagnosis of carpal tunnel syndrome. There are over 20 studies comparing the diagnostic accuracy of ultrasound and electrodiagnostic testing for carpal tunnel syndrome. These studies use either clinical findings or electrodiagnostic testing as the reference standard. One issue with using clinical findings as the reference standard has been a lack of standardization between studies. Use of electrodiagnostic testing as the reference standard assumes a 100% accuracy of this test, which we know is not true clinically. Additionally, most studies used a post hoc analysis with receiver operating curves to maximize both the sensitivity and specificity of the test. Choosing a cutoff value post hoc is not helpful in the clinical scenario. To investigate the ability of ultrasound to confirm a diagnosis of carpal tunnel syndrome, I performed a systematic review that was published in Clinical Orthopedics and Related Research in 2011. The study found that the sensitivity and specificity of ultrasound were 77% and 93% respectively when using clinical diagnosis as the reference standard. In Dr. Graham's classic article from JBJS in 2008, he stated that the sensitivity and specificity of electrodiagnostic testing using stringent criteria were 69% and 97% respectively. My conclusion from this systematic review was that the diagnostic accuracy of ultrasound and electrodiagnostic testing were very similar and that the small differences were likely not clinically relevant. Next, I performed a cost-effectiveness analysis comparing ultrasound and electrodiagnostic testing. We used a Monte Carlo simulation, a statistical method that allows the creation of a fictional population that more accurately reflects clinical practice. For example, the sensitivity and specificity of any given test can vary over the 95% confidence intervals of that test. As every clinician has experienced, most patients do not experience results that exactly mirror the mean or median, but rather fall within a spectrum on either side. The fictional population was created, and then a group of 100 patients from this population was sampled to simulate the clinical spectrum that might be seen in the office by a practitioner. The data from the repeated random samplings was then aggregated and confidence intervals calculated. The prevalence of carpal tunnel syndrome is very important in these simulations, and based on the work of Bob Szabo, we chose a prevalence of 89% in the specialist scenario and 60% in the generalist scenario. Generalists were defined as primary care physicians. We built in penalties for wrong diagnoses and missed time from work. The cost-effectiveness analysis demonstrated that the first-line use of ultrasound was a more cost-effective strategy with use of electrodiagnostic testing in cases where ultrasound did not agree with clinical findings. So with these preliminary studies of the motivation, we performed a prospective study with 85 patients. A complete electrodiagnostic exam was performed according to the standards of the American Association of Neuromuscular and Electrodiagnostic Medicine, but the cutoff values for a positive diagnosis of carpal tunnel syndrome was simplified to a distal motor latency of greater than or equal to 4.2 milliseconds and or a distal sensory latency of greater than or equal to 3.2 milliseconds. These cutoff values are certainly debatable, but have been used in numerous other studies. Also recognize that there is a bias introduced regardless of the cutoff values that are used. A blinded hand fellowship-trained surgeon performed all the ultrasound exams. The cross-sectional area of the median nerve was measured at the carpal tunnel inlet, and an a priori cross-sectional area of greater than or equal to 10 millimeters squared was chosen as a positive test. The CTS-6 diagnostic tool was calculated by a blinded observer, and a score of greater than 12 was considered a positive test. CTS-6 is a validated diagnostic tool developed by Dr. Graham. It estimates the probability of carpal tunnel syndrome based on the presence of 6 classic clinical findings. Each finding is assigned a point value based on a logistic regression model. In Dr. Graham's study, a score of greater than or equal to 12 resulted in such a high pretest probability for carpal tunnel syndrome that additional testing with electrodiagnostic testing provided little clinical additional information. So we used CTS6 as the reference standard and created 2x2 tables. Sensitivity, specificity, positive predictive value, and negative predictive value were calculated. The average cross-sectional area in patients with a positive CTS6 was 12.7 millimeters squared, and the average cross-sectional area in patients with a negative CTS6 was only 7.9 millimeters squared. This difference was statistically significant. The sensitivity of both ultrasound and electrodiagnostic testing was found to be 89%. The specificity of ultrasound was 90% compared to 80% for electrodiagnostic testing. Ultrasound was accurate, meaning it agreed with CTS6 89% of the time. Electrodiagnostic testing was accurate 83% of the time. This difference was not statistically significant. If we were to use electrodiagnostic testing as the reference standard, as was done in many other studies, ultrasound had a sensitivity of 85% and a specificity of 83%. The results of this study confirm our preliminary data that ultrasound can confirm the clinical diagnosis of carpal tunnel syndrome in a select group of patients with a positive CTS6. We are not implying that ultrasound will replace electrodiagnostic testing in all cases or that it is the end-all, be-all of diagnostic tests. However, ultrasound has many advantages to electrodiagnostic testing, including cost-effectiveness, increased efficiency, and less patient discomfort. It also provides a great teaching moment for the patient as they can see the relationship of the nerve to the tendons and the carpal tunnel. This is the first ultrasound versus electrodiagnostic testing study to use a validated diagnostic tool as a reference standard. As described earlier, previous studies used a variable combination of clinical findings, making comparisons between studies difficult. We chose an a priori cutoff of 10 millimeters squared for a positive test. One could optimize specificity, the most important number for a confirmatory test, at the expense of sensitivity by choosing a higher cutoff value. Our study does have several limitations. Our high prevalence population likely inflates the diagnostic accuracy of the tests. Ultrasound is unable to detect cervical radiculopathy, a more proximal median nerve lesion, or changes in the ulnar nerve at the elbow. Patients with a history of or physical examination consistent with one of these diagnoses may be better served with a different test than ultrasound. Finally, it is unclear if ultrasound findings correlate with disease severity. Prolonged latencies on electrodiagnostic testing allow grading of carpal tunnel syndrome severity, and these numbers can be tracked postoperatively. Ultrasound data in this situation is limited at this time. Thank you for your time and the honor of participating in this webinar.
Thanks very much, John. That was very interesting. I'd like to turn it over now to our commentator, Dr. Martin Boyer. Marty, what's your perspective on the information just presented by John?
Thank you. Good evening, everyone. Rather than provide a critique of the study just communicated by Dr. Fowler, I'd like to further inform the audience about several studies to which Dr. Fowler has referred and place them in the context of his groundbreaking work. The first is a paper by our moderator, Dr. Graham, wherein he describes the usefulness of electrophysiological assessment in the diagnosis of carpal tunnel syndrome. He uses the CTX6 evaluation metric described by Dr. Fowler to assess whether or not adding electrophysiological testing was useful in terms of changing the probability of diagnosing carpal tunnel syndrome in those patients with varying pre-test probabilities of carpal tunnel syndrome. He found that an appropriate history and physical examination-based diagnosis of carpal tunnel syndrome was not improved upon by added electrophysiological testing. Furthermore, he found that the greatest usefulness of electrophysiological testing was in those patients with a lower pre-test probability, and it was in those patients that the probability was lowered. Electrophysiological testing was therefore useful as a negative test in those patients with low pre-test probability based on the CTS6. With a stated interest in this new diagnostic modality, Dr. Fowler performed a meta-analysis, as he's mentioned, of all studies that had previously attempted to evaluate ultrasound as a screening or confirmatory tool for carpal tunnel syndrome diagnosis. With a sensitivity of 77.6% and a specificity of 86.8%, Dr. Fowler and co-authors felt that ultrasound might be useful as a first-line confirmatory test for the diagnosis of carpal tunnel syndrome. He followed up this conclusion with a cost-effectiveness analysis published in Clinical Orthopedics and Related Research and argued that as a first-line confirmatory test, ultrasound was more cost-effective for confirmation of the diagnosis of carpal tunnel syndrome in a specialist population. In effect, he was saying that those with a higher pre-test probability benefited in a cost-effectiveness sense from having the diagnosis confirmed preoperatively by ultrasound rather than by electrophysiological testing. An algorithmic approach to the diagnosis of carpal tunnel syndrome by history, physical examination, and either electrophysiological testing or ultrasound examination was presented, and I would urge the audience to avail themselves of the opportunity of familiarizing themselves with this flowchart. In closing, I'd like to congratulate Dr. Fowler on a thought-provoking paper. He does not attempt in his most recent work that is covered in this webinar to usurp electrophysiological testing's useful role in diagnosis of carpal tunnel syndrome and estimation of carpal tunnel syndrome severity in appropriate patients, but rather to inform us on the potential for a non-invasive, more inexpensive, and potentially patient-friendly as well as immediate technique for initial carpal tunnel syndrome screening. Thank you.
Thanks a lot, Marty. We've actually received quite a few questions from our audience members, and I think we have a few minutes to pose one or two of these to Dr. Fowler. John, one of our audience members asks, are radiologists at your facility trained in interpreting ultrasound in the diagnosis of carpal tunnel syndrome, or do you interpret the studies yourself? And I think this gets at one of the main concerns about ultrasound, namely the fact that it's very operator dependent.
Sure. So I perform all of these myself in the office and just interpret them right away. And the advantage of that is you get an immediate answer. But I think you're right. I think there definitely is a learning curve. And we are doing a reliability study right now comparing experienced people to first-year residents and trying to determine how accurate they are and how they compare to our values as well.
That's interesting. One of the other audience members asks if you're just looking at the size of the nerve, and I guess implicit in that question is, are there other characteristics on ultrasound that contribute to your sort of imaging diagnosis of carpal tunnel syndrome, or is it just simply the size as the main parameter?
So at least in our study, size was the only factor that we really looked at. There's been some other research looking at things like wrist-forearm ratio of the median nerve. Some other studies have looked at the overall size of the carpal tunnel itself compared to the size of the nerve and looking at that ratio. But specifically in our study, and in my general practice, I just look at the absolute size of the nerve.
Another question that comes from the audience is the following. Is there expansion of the nerve on ultrasound postoperatively, and what percentage in volume corresponds with a good result? So this is pretty interesting, especially from the standpoint of the patient who may not do as well clinically. Do you think that there's a role for ultrasound in monitoring the size of the nerve postoperatively to give us some clue as to whether or not our surgery has been successful beyond the clinical assessment?
Yeah, I think there's definitely a role, but there's very little data out there right now. We have a very small pilot surgery or study where we looked at 11 patients and brought them back a year later after their surgery. We had pre- and post-op ultrasound cross-sectional areas, and in 7 of the patients, the nerve size got smaller. In 2, it got worse, and then in 2 others, it stayed about the same. So we're not 100% sure what that means, and we're trying to expand that study right now to get larger numbers and try to determine how those factors relate to patient outcomes and symptomatology and things like that. But I would say that if this, in my opinion, if the treatment worked, you would think that the nerve swelling would decrease a year after surgery.
Yeah, I think it's going to be some important data when you collect that. Another question from our audience was to ask you to just explain, perhaps in a little bit more detail, the exact landmarks for the carpal tunnel inlet when you're using ultrasound. And my guess is that this is a pretty important factor in really assessing what the nerve looks like.
And so this was looked at extensively early on in ultrasound, and they try to compare the carpal tunnel inlet versus the middle of the carpal tunnel versus the distal edge of the carpal tunnel, and they found that the carpal tunnel inlet was the most accurate place to measure. And so usually what I do is I take the distal most part of the wrist crease and place my ultrasound probe there. Alternatively, you can palpate the pisiform and then try to line up your probe with the edge of the pisiform.
We'll just ask one more question from the audience. One of our participants has asked whether or not ultrasound has any use in diagnosing recurrent carpal tunnel syndrome after a carpal tunnel release. And I guess this relates a little bit to the earlier question about the changes in the nerve postoperatively, but do you think there are any other ultrasound characteristics that would be useful in evaluating that kind of patient?
I mean, I think there's definitely a lot to be still studied. There's almost no data for recurrent carpal tunnel syndrome and use of ultrasound, but you're right. I mean, we have classically used nerve studies in trying to track how well the nerve conducts a signal, but that may not be the best marker overall. And so I'm very interested in looking at that long term, trying to see if nerve swelling or nerve vascularity or other factors inside the carpal tunnel could predict recurrence or people getting better like we talked about earlier.
Yeah. Well, ultrasound is getting better all the time in terms of its resolution, so there may be some help in that regard. Okay, we're going to move on, and next I'd like to ask Dr. Daniel Osei to present his paper.
So thanks, Brent, for allowing me to participate in this webinar tonight. Prior to the onset of our study, my partners and I at Washington University were curious about the value of treating patients with bilateral carpal tunnel syndrome with simultaneous bilateral carpal tunnel release. In attempting to research this concept, we came across a paper by Angela Wang and her colleagues at the University of Utah. In that study, Dr. Wang reported on the functional limitations experienced by patients undergoing bilateral carpal tunnel release. In doing so, she and her colleagues attempted to explore the utility of bilateral carpal tunnel release, which is a particularly relevant question given the 60 to 70% of patients with carpal tunnel syndrome who present with bilateral symptoms. While informative, their findings left unanswered the more relevant question: how is post-operative function affected by the decision to undergo bilateral release as compared to unilateral staged carpal tunnel release? To investigate the concept of simultaneous bilateral carpal tunnel release further, in 2012, we decided to query the collective wisdom of the American Society for Surgery of the Hand. In our survey, we found that only 15% of hand surgeons were likely to offer simultaneous bilateral carpal tunnel release to a patient presenting with bilateral symptoms, which suggested to us that most hand surgeons favored staged procedures. These issues provided the impetus for our study. Based on the findings of the aforementioned survey, our first aim was to compare postoperative difficulty in performing activities of daily living in patients with bilateral carpal tunnel syndrome undergoing either unilateral or simultaneous bilateral carpal tunnel release at the time of their index surgery. Our second aim was to determine why patients chose unilateral or simultaneous bilateral carpal tunnel release when either treatment was appropriate. Our hypothesis was that due to necessitating operative incisions on both hands, simultaneous bilateral carpal tunnel release would lead to significantly more short-term impairment, making bilateral surgery a less favorable option. In acknowledgement of the fact that carpal tunnel treatment is highly dependent on individual patient preferences, our observational study employed a prospective dual cohort patient preference design. We prospectively enrolled all patients with clinically and electrophysiologically confirmed carpal tunnel syndrome, and after employment of a standardized treatment discussion utilized by all participating surgeons in the study, we offered patients the choice of either procedure. In end, this included 47 patients enrolled in the bilateral carpal tunnel release group and 42 patients in the unilateral carpal tunnel release group. We collected QuickDash and Boston Carpal Tunnel questionnaire data on all patients preoperatively, on postoperative day 7, and on postoperative day 28. We also had patients rate the difficulty that they experienced performing activities of daily living over the first 7 days after surgery, similar to the methods of the study of Wang et al. In comparing our two cohorts preoperatively, we found that patient age, sex distribution, and pre-op quick dash scores were similar in the two groups. In looking at the results after surgery, we found that quick dash scores and Boston Carpal Tunnel Questionnaire scores did not differ between the bilateral and the unilateral cohorts at either the first postoperative visit or at the second postoperative visit. The following slide is an example of one of the 15 activities that patients attempted each day and rated each day for the first 7 days after surgery. The graph depicts the mean difficulty that each of the 47 bilateral carpal tunnel release patients had in using the bathroom when compared to the 42 unilateral carpal tunnel release patients. What we see here is that patients undergoing bilateral carpal tunnel release had no more difficulty using the bathroom than did patients who underwent unilateral carpal tunnel release at any point during the 7-day period. This was also true of other hygiene-related activities that we rated during the post-op period, such as showering, as well as non-manual labor activities such as using a computer or buttoning a shirt. In contrast to the findings presented at the last slide, when patients attempted manual labor-related activities that required heavier lifting or gripping, such as things like household chores or cooking, as depicted here, patients in the bilateral group had significantly more difficulty over the first 2 days. The groups starting at day 3 and progressing to day 7 were equivalent. In examining the reasons why patients opted for unilateral or bilateral carpal tunnel release, patients who chose unilateral carpal tunnel release most commonly identified worries regarding ability to care for themselves, while patients who chose bilateral carpal tunnel release did so primarily due to a desire to avoid 2 surgeries or to achieve quicker relief from their bilateral symptoms. We then looked closer at the relative importance of assistance at home between the 2 groups. While a large number of patients in both groups required help during activities of daily living, patients who underwent bilateral carpal tunnel release required significantly more assistance during the first few days following surgery, both with regard to hygiene-related activities as depicted in the top row, as well as with other activities of daily living. In an attempt to determine a consensus amongst patients about what factors were most helpful in allowing them to perform activities of daily living during the first few days after surgery, 71% identified help at home, making this the single most important factor. As part of our group's standard postoperative carpal tunnel release protocol, we give all patients, whether they undergo bilateral or unilateral carpal tunnel release, extra large latex gloves which can be placed over their operative bandages so that they can perform activities of daily living without soiling their bandages or getting their bandages wet. 63% of patients found these gloves to be very helpful during performance of ADLs and may have contributed to their ability to do so independently. We then apologize with the slides. It has been a decade since Wang and her colleagues published the findings regarding functional limitations after bilateral carpal tunnel release, and yet the concept of simultaneous bilateral carpal tunnel release has not been universally accepted into practice amongst most hand surgeons. Our findings support and add to these previous results and may help patients and surgeons better understand the potential trade-offs involved with the decision to pursue either simultaneous bilateral carpal tunnel release or stage procedures when carpal tunnel release is needed in both hands. In conclusion, patients who undergo bilateral carpal tunnel release can anticipate 2 to 3 days of additional impairment, specifically with activities that require heavier gripping or lifting, such as cooking or doing household chores like laundry. Surprisingly, despite the fact that patients who choose unilateral carpal tunnel release do so primarily due to worry about self-care, patients who undergo bilateral carpal tunnel release have no additional perceived difficulty when performing hygiene-related ADLs or non-manual labor-related activities, as demonstrated through their own self-determined impairment scores during the first week after surgery. Beyond postoperative day 3, postoperative impairment is similar regardless of choice to undergo bilateral or unilateral carpal tunnel release. Due to these findings, all of the hand surgeons within our group have changed their practice and routinely offer and perform bilateral carpal tunnel release in patients who present with significant bilateral symptoms when surgery is indicated on both hands and when the patient feels that this may be a surgery that would benefit them. Thank you, and at this point I'll be happy to answer any questions.
Thanks, Dan. I'd like to call on Dr. Pomerantz now to comment on your paper.
First, I'd like to thank everyone for inviting me to tonight's webinar and also congratulate the authors on their paper. The paper had a number of strengths, including its high level, its adequate power and statistical analysis, as well as the use of outcome tools intended to measure the study issues. It also attempted to answer a question that's really common to all surgeons who treat carpal tunnel syndrome. The weaknesses of the study were that it really lacked information on the preoperative education and the associated conditions each patient may have. There were some forms of bias introduced in the study, most commonly the selection bias. We had a short follow-up and a subjective rating by patients that really lacked uniform standards, and there was really no tool to measure patient motivation. I do have some questions for the authors. There was a very high rate of pillar pain, including patients who had a unilateral release actually higher than the bilateral patients. Why was this so high? How long did it last? And what really was done for it? And could it have accounted for the early impairment in and of itself? Was there really any difference in return to work times between the study groups? And did the authors routinely use therapy? Would more patients choose bilateral surgery, knowing the economic benefits, knowing that a single surgical procedure is much less in cost, at least in the United States, than staging the procedure into two separate procedures? And would the workers' compensation status of the patients alter the outcomes of the study? It appears that the choice was really driven by the patient's desire to either have the problem over and done with in the bilateral patients, or the patients who chose the unilateral surgery to make sure that after surgery they were able to care for themselves and be less of a burden to others. Overall, I think this was a very good study that should help a number of surgeons in discussing this condition with the patients. I know I've been offering bilateral surgery to my patient population for a number of years, and I appreciate the study as a way to confirm this as being a safe and reasonable option for patients. Thank you.
Thanks a lot, Jay. Dan, we're getting a number of questions related to your paper too, and even though we're a little bit before the general Q&A session, I think it's fine to just start right now. One question that's come in that I actually had not really thought of at all myself was the following. That is, what type of anesthesia do you use with bilateral carpal tunnel release, and where do you put the IV?
So, Brent, that's a great question, and it is a decided difference between the way we typically do our unilateral carpal tunnel release. Like many people, we use either a local or a regional anesthetic, versus with bilateral, we typically undergo a LMA type of general anesthesia. Certainly with regard to the IVs, that always comes up as a problem. In our practice, we routinely use forearm tourniquets, and in that case, it can be sometimes difficult depending on where the IV is placed. In the case of bilateral carpal tunnel release, we usually use an antecubital IV with the forearm tourniquet directly underneath, and it seems to work, although admittedly the space is somewhat tight. So
what that suggests to me is that if the patients that have bilateral carpal tunnel releases done, simultaneous bilateral releases done, are having all having a general anesthetic, that must have some impact on the cost, and perhaps that mitigates the the savings incurred by doing it that way as opposed to doing it sequentially. Do you have any comments about that?
Sure. So actually this is, and that was one of Jay's questions regarding cost and value to patients. So sort of questions in the realm of cost effectiveness. That's actually the study of the subject of a follow-up study that we are currently undergoing right now, looking at some of those other factors. In our institution, we've actually looked at our anesthesia data, and what we find is that the actual cost for a regional anesthetic is fairly similar to a general anesthetic. If someone needs to undergo both a general and a regional, then that roughly doubles the cost, maybe a little bit less so. So I wouldn't say that the choice between general and a regional necessarily increases the cost on the case of the bilateral group.
Several of the audience members have asked questions related to the possible diagnosis of the condition of bilateral carpal tunnel syndrome being more central, for instance, coming from the cervical spine or somewhere proximal to the carpal tunnel, and seemingly that would be more likely in a case of bilateral carpal tunnel syndrome that presents that way. So what kind of investigations does your group do to rule that out, or how do you approach that?
So I think most hand surgeons are familiar with the potential anxiety over the possibility of a more central cause of numbness and tingling, particularly in the thumb and the index finger, given the relative high incidence of, say, C6 radiculopathy. For most of us, and I don't know that I can speak routinely for all my partners, I think we certainly try to figure out, the pre-test probability, and we talk about this with our residents. So does the person have neck pain? Do they have problems with neck range of motion? Often utilizing things like a Sperling sign and really a little bit of a modified cervical spine examination in the context of the clinical examination. I think that a lot of the things about our provocative tests, such as Tinel's, Durkin sign or median nerve compression, and Phelan's, tend to localize the lesion quite well. And of course, just like in our study, the use of electrodiagnostic tests as well as ultrasound may be adjuncts that can be helpful to try to distinguish between central and peripheral causes of nerve problems.
Terrific. One of our audience members asks what your thoughts are on endoscopic carpal tunnel release and whether or not that modality would make bilateral carpal tunnel release more palatable for a patient.
Another great question. So that's actually a question that has been examined and investigated in the literature. If one were to do a PubMed or Embase search for bilateral carpal tunnel release, what you'd find prior to our study is that the vast majority of studies have investigated endoscopic carpal tunnel release. At least from an anecdotal standpoint, I believe that most people would say that the relative incisional pain that could occur with the open or mini-open procedure may be mitigated with endoscopic carpal tunnel release, which may be one reason to consider that as the modality should you wish to perform bilateral carpal tunnel release. From a cost-effectiveness standpoint, however, one could certainly look at the relatively higher costs associated with endoscopic carpal tunnel release as a potential downside. And so one of the reasons that we wanted to investigate open carpal tunnel release was to see whether the perception of increased incisional pain or limitations associated with an open surgery truly corresponded with and resulted in increased impairment in a bilateral group.
Thanks. Another one of our audience members asks that, or asks you to comment on the observation that the majority of your patients wouldn't recommend the bilateral procedure. What do you think that means? Because this audience member said that you didn't really mention that in your comments tonight.
So that's a good point, and there's a lot of minute details that I think are very important that were part of the study that are hard to kind of encapture in a 10-minute presentation. That comment relates to whether or not someone would recommend bilateral carpal tunnel release to someone if they did not have help with them at home for the first week after surgery. So that's not to say that they wouldn't recommend the procedure at all. It's to say that if a person did not have help at home during the first 7 days, would a person who's just undergone bilateral carpal tunnel release recommend that to another person? What I think is actually notable about that statistic is that greater than a third of those patients would actually recommend that procedure even if somebody did not have help at home, which actually suggests that those patients felt that functionally they were able to operate independently at home even during that first 7-day period.
I think it'd be interesting if you have any way of measuring the sort of self-assurance of some of these patients, because that seems kind of brave. Another audience member asks whether or not the patients in your study required postoperative occupational therapy. And I might add to that, do you think that the patients that had bilateral surgery were more likely to require some adjunct rehabilitation afterwards as opposed to the patients that had bilateral surgery?
So that's a question that has come up a few times as I've discussed this paper, and actually came up in the editorial process during revisions. As a group, and there's 6 of us in our group at Washington University, we do not send patients routinely to occupational therapy. And I would say it's the rare patient that comes back with continued stiffness, continued incisional pain that may require desensitization or scar massage or other ultrasound-related modalities that ends up going to occupational therapy. I don't have a number for the audience member that asked the question, but I would venture a guess that it's less than 5% of patients that ultimately end up with any occupational therapy-related help after either unilateral or bilateral carpal tunnel release. That's just our group.
Yep, I think we have a similar experience with our carpal tunnel patients as well. Dr. Fowler, there's a question for you. One of the audience members would like to know what transducer frequency you use and whether or not you use the standoff method.
So I use a 15-6 megahertz linear array transducer. I've played around a lot. They make the smaller ones that are good for injecting things like trigger fingers, but I think that the kind of the standard size transducer is the best one for doing cross-sectional area of median nerve. And I have not used the standoff method. I actually didn't know what that was. I looked it up briefly. It sounds like a way to try to standardize the measurement on the carpal tunnel, but I've had great luck just doing it normally.
Thanks. I had a question myself for you, and that is, I noticed that at the end of your paper you indicated that ultrasonography, diagnostic ultrasound, was less expensive, it was less painful, and was more palatable to patients than electrodiagnostic testing might be. And in fact, you mentioned that it gave you an opportunity for a teaching point with the patients as well, and that's always a very valuable, value-added aspect to something like this. So if that's all true, why would you conclude that it should not replace electrodiagnostic testing? That seems to be the logical conclusion that somebody might arrive at based on your findings.
Sure. I mean, I think that we just don't have the data to say that definitively yet. I mean, I think that in my heart I believe that, but we've only really shown with good data that it can replace it very reliably in patients with a positive CTS6. Now, going forward, we're definitely looking at trying to expand that indication and try to look at it in patients with more non-classic findings. But for now, I think until we actually show the data, it should probably still be only stated it's good in that single indication for now.
Dan, one of the audience members asks a question that I think is important, at least in my practice too. And this audience member asks whether or not your patients wear a brace after the surgery. And I have to admit that bereft though it may be of evidence, I have always placed my patients not just in a brace, but I actually placed them in a cast after surgery for a couple of weeks, mostly to prevent them from doing a Phelan test all night after my surgery. So did your patients wear a brace after surgery, and if a surgeon had that as their practice, would that be basically a relative contraindication to doing bilateral surgery?
So two related but somewhat different questions. In our group, we do not brace, we do not cast, we do not splint after surgery. Patients go home in a small, soft postoperative dressing consisting essentially of gauze and either an ACE wrap or a Coban dressing. There have been many studies that have looked at evidence for need for splinting after surgery, and I think both sort of level 4, level 3, and even some level 5 papers have suggested that practice has become a little less common, though obviously there are many surgeons, including yourself, Dr. Graham, who do. Anecdotally, I have not seen people present with sort of recurrent radicular type symptoms or numbness and tingling, signaling that they're sort of giving themselves a self-valence. People have really done quite well. If you look at our study, we actually allow people to go back to just about everything in their normal life: cooking, cleaning, household chores. The main limitation that we put on patients is no lifting more than 10 pounds on the operative side. That becomes more difficult in the bilateral case, which is one of the reasons that we felt that it was so important for patients to have help over that first week. But if you really look closely at the graphs from the paper, and I know we only have 2 of them here, really, again, only with heavier types of activities, lifting heavy pots and pans, doing household chores, did we see patients rating their ability on a scale of 1 to 5 any higher in the bilateral group. So I think our concerns as surgeons perhaps do not predict what patients are able to do or what they necessarily experience, even when left to their own devices to go back to activities or even early on.
John, one of the audience members asks actually a very interesting question, and that is, do you ever see anatomic variants with ultrasound that alter your surgical approach?
It's a very interesting question. I've definitely seen several bifid median nerves, and my standard practice is actually to do endoscopic carpal tunnel. I think my patients get better a little quicker anecdotally, but if I do see that bifid median nerve on ultrasound exam, I'll do it open just to make sure I don't do anything stupid and cut a nerve.
Yeah, I think that's very interesting, actually. Dan, one of the questions I also had for you was, your patient population basically comprised people who chose their treatment for themselves, and you've sort of alluded to this a little bit. Do you think that this is the type of standard of practice that should be considered an option, or do you think that we should, in our discussion with patients, try to persuade them that this would be the right treatment for them because of all the potential advantages of having their surgery done bilaterally simultaneously, even in light of some possible short-term impairment or disability lasting a few days?
So I think that point and the conclusion or the answer to the question is one of the most important things that I think is a take-home from the paper. By no means is, in my mind, the conclusion here that bilateral carpal tunnel release is right for everyone, or perhaps because of some of the expedience with which you may, get both of the surgeries out of the way, that's the way to go. This study basically says that in a person who is interested and motivated, you can expect them to do as well, on average, essentially, as somebody who undergoes unilateral carpal tunnel release. Had we done a randomized controlled trial, I think that the results may have been very different. And this speaks to the reason why we chose not to do a randomized trial and really make it more practical, which is the way that patients present. Some patients are highly motivated and want to get back to things. Other patients may be a little bit more difficult to push along and may take a little bit more TLC from their surgeon to get them from pre-op to surgery and then recovery after surgery. So I very much feel that patients should be individualized in terms of their care based on a lot of the other subjective things that certainly make up their psychological profile as well as their motivation.
Yeah, I think that's an excellent answer, very insightful. We're getting a few questions from our audience members just about the care of carpal tunnel syndrome in general, or at least the post-surgical care. One of the audience members asks what kind of follow-up you do with your patients and what percentage do you identify a recurrence of symptoms in? And maybe I'll ask John to comment on that first and then Dr. Osei.
So my standard follow-up depends a lot on how they feel at that 2-week visit. I think that the patient that comes back after endoscopic carpal tunnel release especially, and they've either returned to work or their symptoms are mostly better, their night pain is resolved, their daytime numbness is gone, I generally will let those patients come back on an as-needed basis. Sometimes the more severe carpal tunnels, the ones with atrophy or no response on the electrodiagnostic testing, they're not better at that 2-week visit. They're still having either daytime numbness, and I'll usually see them back at least at the 6-week visit and sometimes even at 3 months just to check on them, make sure they're doing okay. With respect to recurrence, I haven't been in practice that long, so I honestly can't say I've seen any of my patients come back with recurrence. That probably just means that it's seen me and I haven't seen it yet.
Dr. Osei, do you want to comment on that as well?
Sure.
And recurrence?
So I guess my practice is a little bit different, but probably fairly similar in philosophy. In general, it seems that patients do quite well after carpal tunnel release. My standard follow-up is a little bit earlier than Dr. Fowler's. I see people back roughly in the 8 to 10 day range to make sure that they're doing well immediately after surgery, to answer questions about my expectations for their kind of functional recovery moving forward. I then see patients back roughly at a month, so it actually mirrors a little bit of the methodology of the paper that we presented here today. My primary reason for seeing all my patients back on that second visit, despite the problems with global period, is again educational. And I find that from a patient satisfaction standpoint, telling them about what to expect, telling them about incisional soreness and that I expect that to get better in sort of the first 4 to 8 weeks, reassuring them about the types of limitations that they may have or restrictions that they may have based on a job is helpful, and I find that that usually leads to high patient satisfaction. I generally allow all my patients to go back to work if they're not a laborer as soon as they feel comfortable, and laborers I keep out of work for the 4-week time frame and then let them go back, assuming that everything is going well. With regard to recurrent carpal tunnel, like Dr. Fowler, I really haven't seen much. I've seen one person in practice who had sort of persistence of symptoms, but I can't honestly say that I can think of anyone who's come back with a recurrence. Though I have seen, a couple people from other surgeons, and maybe 7, 10 years down the road. So it seems like it's a fairly durable and consistently successful surgery from what I've seen thus far.
We just have time for 1 or 2 more questions. One of the audience members has asked something pretty interesting that I hadn't thought of myself, and that is, and maybe this is a question more for you, Dan, what are your thoughts with the patient who has maybe very significant symptoms in one hand and lesser symptoms in the other hand? Do you think that that person should still undergo bilateral simultaneous carpal tunnel releases, or do you think that there's a role in that kind of person for doing a unilateral carpal tunnel release and, say, a steroid injection, which the last guideline indicated was a viable treatment in the less symptomatic hand? Or do you think that those patients should have bilateral releases?
That is a wonderful question by the audience member, and I think, we sort of alluded to this about the, need to individualize patient care. I actually think that both of those options are reasonable in a patient who presents with clearly one side worse than the other. In general, if it's a clear difference, I tend to lean towards unilateral carpal tunnel release with some kind of non-operative treatment, whether it be an injection or simply nighttime splinting and activity modification, staying away from those activities that provoke symptoms. In general, my feeling long-term is that those patients will eventually end up with increasing symptoms, or what I've seen more often in practice is that someone appreciates the level of symptoms that they have in their less symptomatic hand much more after they've had relief from their other side. So oftentimes the patient comes in, says my left hand is worse, we end up doing unilateral carpal tunnel release. They come back even 8 days after surgery and say my hand is killing me and I just didn't realize how bad it was because the other side was so much worse. So for that reason, I'm less reluctant, I suppose, to offer that person bilateral carpal tunnel release. But again, I'm careful to make sure that electrodiagnostically, as well as kind of from a clinical standpoint, I'm not fooling myself into believing that the person has bilateral disease.
Dr. Boyer, you commented on Dr. Fowler's paper, but you work at the same institution as Dr. Osei, so would you have the same point of view about the patient with significant involvement in one hand and lesser involvement in the other hand?
I think it has to be individualized, Dr. Graham, but I would tend to probably be a little more on the aggressive side and try and educate the patients on the benefits of having both done at the same time. I myself have had bilateral carpal tunnel release done simultaneously. One side was a lot worse than the other, and I decided to just have both done at the same time to save myself from the aggravation of another surgery. So I speak from experience. It's not an easy thing, but I'm glad I had them both done at the same time.
Wow, that's a personal testimonial. That's pretty interesting. Dr. Fowler, do you have any comments about the role of unilateral versus bilateral surgery, and have you used that in your practice?
Yeah, I mean, in general, I think I've only offered unilateral, and when people request it, I think I've probably done 4 or 5 bilaterals in my 2-year career. I think it all depends on the person, and some people put up with it much better than others. And I think a lot of what Dr. Osei said is very true. I think in Dr. Boyer, you have to individualize each person.
And I guess we could give the last word on this topic to Dr. Pomerantz, who is in private practice and may have a slightly different perspective than the other speakers who all work in academic institutions. Jay, do you have some comments about unilateral versus bilateral surgery, at least in your own practice?
Sure. I pretty much take the approach that Dr. Boyer does in educating the patient and letting them know what it is they have, and also, if you're to review the literature, that the natural history of somebody with a bilateral carpal tunnel syndrome, that over a period of months to years, they will become symptomatic enough to the point where they typically come back, if not for surgery, at least for additional treatment, whether that be a steroid injection. So I think that the more the patient does know and really understand what they have, that the better they can make a decision. So I would really probably encourage the patient to have the bilateral surgery if they feel their hands are symptomatic. Apropos of Dr. Osei's paper, that I believe 22% of the patients in their study that they still had symptoms that were waking them at night due to the unoperated hand. So that fact alone may sway someone to want to proceed with surgery at an earlier time, not necessarily being a bilateral surgery, but certainly staging it, let's say, weeks to months apart.
Thank you. Before we close this session with Dr. Swiatkowski's final remarks, I want to thank our speakers for these presentations and also thank all of you in the audience for joining us. As you exit the webinar, please take a moment to fill out the short survey, which will help us evaluate this presentation and also plan for future webinars. And I hope you found this session valuable. Dr. Swiatkowski?
I'd like to thank Dr. Graham and all the speakers for putting together today's webinar. We hope that you enjoyed this presentation. This webinar will be archived for 6 months in the event you or your colleagues would like to listen again. We also want to thank, again, our sponsor, Modernizing Medicine. We look forward to hearing your feedback on tonight's webinar. Enjoy the rest of your evening, and we hope to continue to bring you information in formats that are convenient for you. Thank you, and good night.